J S Kumar and Professor A. Ramachandran, known in the field of diabetes very well. They don't require much introduction. Anyhow, the custom demands. Madam will introduce.
Thank you, Dr. Vijayakumar, for inviting me to be the chair of the session. I invite Professor J S Kumar, Professor of Medicine, SRM Medical College, to start the.
Good afternoon. At the onset, I would like to thank Vijayakumar and his wonderful team of my colleagues for organizing this session. And since there is no much time for me, it's hardly 15 minutes, I believe, I'll directly go to the topic. The topic given to me is on insulin initiation in clinical care, and how are we going to start doing things. We know a lot, and we have been attending a lot of conferences, and we know the importance of insulin, but is there any kind of easy way of initiating insulin, and how less arduous the task can be made if you can make things like titration to be as simple as possible. So to go through this, I'll take hardly 15 minutes, but then let us look at the current scenario of diabetes in India. You could see that we have that IDF have estimated almost 73 million of people around the world suffering from diabetes, and India alone you have around 36 million people. Unfortunate thing is that almost 50% of us, especially in the audience, whom we claim to think that we don't have diabetes, especially with one family member who is having diabetes, we all have some amount of dysglycemia. Call it pre-diabetes, or call it impaired glucose tolerance, or impaired fasting glucose. So we are in an area where diabetes has become so common, and sometime or other there must be a primary prevention going on at the earliest of 30 years for all Indian citizens. Said that, we like to know that 90% of these patients have, unfortunately, even though they have been diagnosed diabetes, glycemia is not under control, and they go for various comorbid conditions, both macro as well as macrovascular. So let's start with an hypothetical case. A 54-year-old man who's diabetic for 5 years. This is especially for postgraduates as well as the interns who are interested to know how to start with insulin. Very basic slide deck is what I'm going to present to you, because we know that starting insulin should be as simple task by a person who has just graduated or been trained in internal medicine. This patient has come to your office with excessive fatigue, polyuria for the past 1 month, has burning micturition for the past 10 days, no history of hypertension or any established heart disease, currently on metformin of 1 gram twice daily with glimepiride 2 milligram twice daily. His body weight is 60 kilos, BP 120/70, unremarkable review of systems. His echo shows probably a grade 1 diastolic dysfunction to maybe to tell, but the ejection fraction is 65%. Negative for microalbuminuria and fundus. It doesn't show any evidence of retinopathy. His blood parameters include fasting of 220, postprandial of 290, and A1C of 9.3, and serum creatinine of 1.1. So, the question thrown to the audience is that what do you do next? Do you initiate pioglitazone or any of the following drugs? OHAs or injectables, GLP-1 and receptor analog, or insulin. So the question is, since the theme is on initiating insulin, so the answer should be on insulin. But the question is, why not others? So if you want to look at some evidence to throw it, there is an INSIGHT study which was done on an RCT on add-on insulin versus with conventional therapy. You could see that add-on insulin Glargine, starting with basal insulin Glargine, on patients with type 2 diabetes on OADs, who are insulin naive, improved glycemic control to near normal physiological levels. So by adding a basal insulin and Glargine in this context, you could see that more number of patients had a near to normal physiological insulin leading on to glycemic control. So What would be appropriate therapy? So probably this patient, the best therapy for me, because he has fatigue, he has osmotic symptoms, probably the rest of the drugs may not be the ideal candidate. SGLT2 probably cannot be given because he already is having urinary tract infection and there is no established cardiac disease. So probably GLP and 1 receptor analog as well as SGLT2 may not be the need of the hour for this patient as of now. So the evidence suggests that addition of OAD as a third agent in uncontrolled type 2 diabetes is likely to be less efficacious. Therefore, initiation of insulin therapy is considered good for this particular patient. Said that, what insulin would you like to initiate? Now you have a basal insulin as well as premix insulin. All of us know that we are very much comfortable in using premix insulin, but to initiate, most of the guidelines have come with one insulin as the best insulin to start with because it is less arduous and more easily to titrate, and patient usually won't go for any complication, especially hypoglycemia. Except for the Indian recommendation guidelines where premix or core formulations may be used as the initiating insulin. Otherwise, most of the guidelines advise us or guide us to start basal insulin as the first injectable. So let us look at the pros and cons of basal as premixed. You could see the basal insulin is recommended as an ideal insulin as most of the guidelines, although the action is slower because you know that basal insulin controls the fasting blood sugar best than the prandial insulin. So be it. So to get your A1C from 9.8 as this patient had, to get this at least to 7.5, I think this basal insulin with OADs will work. Then you want to fine tune it, then probably you require a better prandial control. But if you're looking at a premix insulin, they are complex regimen and is associated with increased hypoglycemic events as well as weight gain. So the treatment adherence is affected because of the unsafe, that kind of safety profile may be unsuitable for especially elderly patients to start with. They can go for nocturnal hypoglycemia. So basal insulin probably has a greater efficacy compared to premix insulin as per this study, where in patients with type 2 diabetes uncontrolled, inadequately controlled with oral therapy, adding a single injection of insulin glargine can provide more effective glycemic control than a premix insulin which has to be used twice daily. So less number of injections, less number of hypoglycemic events, and easy for the patient to manage. Probably these are the patients who may not require a self-monitoring of blood glucose, but if they have a self-monitoring, glucometer available, they need to check their sugars probably in the first 3 days and do the titration on the third day. So you need not that every day they have to do that kind of titration. So making a choice of contemporary basal insulin, you could see that we have a real-world data. So now you say that probably there will be some quarter saying that, okay, this may be a Sanofi-funded trial. So let us look into what is the real-world data where patients do live in their own comfort zone and they don't been under the scrutinies of the primary investigator. So this trial done on Asian patients, the real world data tells us that significant reductions of A1C and fasting blood glucose were achieved by using glargine versus compared with NPH or initiation of Detemir in Asian patients with type 2 diabetes. So in real world settings is I think the one that you have to take as much as close as possible to your patients coming to your office. So reduction of weight as well as less hypoglycemic events were seen mostly in patients put on insulin glargine compared with insulin NPH as well as Detemir. So you have the better efficacy with glargine. This is again the BEGIN study, and again if you are looking at the degludec study, by cumulative events of hypoglycemia were less and they were statistically confirmed comparable with IDEC, even though numerically it may be little on the lower on degludec, but if you are looking at the p-value, it was only 0.2. So let's look at the origin trial data, the messages. Insulin glargine had a neutral effect on the incidence of cancer as well as cardiovascular outcomes. Insulin glargine was associated with sustained reduction of both HbA1c and the fasting blood glucose. Insulin glargine may progress, this is very, very important, may delay the progression to overt type 2 diabetes. So starting insulin quick for a short period of time can probably get the glucotoxicity down, improve the insulin resistance, and maybe probably a good primary prevention program for a few subpopulation of type 2 diabetic patients. So look at the wall of evidence. You have the number of review articles, 607, because this is the first insulin that has been studied, investigated. So you have a lot of trials, and you have clinical trials, almost 37 in India. So if you look at this diabetes care issue in 2016, they have Glargine is still considered as the gold standard basal insulin. Now we have new derivatives already been used. No doubt about it. The more and more better version comes in, there will be better pharmacokinetics and dynamics, can lead on to better less number of hypoglycemia as well as weight gain. But as of now, still Glargine is being currently regarded as the gold standard basal insulin. And very, very simplistic thing, this is for the new medical graduates into the field of diabetology, is that very easy titration depending on the weight. So either you take a 60, 80 or 100 kilo patients with an A1C of 8 or 9, you can start with as low as 0.2 units per kilogram, you can go maximum to 0.3. So you can play with 0.2 to 0.3 units per kilogram. So roughly the rule of thumb will be start with 10 to 12 units and then up titrate. And if he's going to be an obese patient, you can jolly well titrate and start with 20 units per day. And conventionally, we start once in the night. For elderly patients, personally, I feel that you can start Glargine on the morning just to make sure that they don't go for hypoglycemia if they also have CKD. So continuing with this patient A1C, which was 9.3, was started with Glargine at 0.3 unit per kilogram body weight. And for him, looking at the amount of units per day, it was around 18 units. So starting at a lower dose is fine. But only thing is that we should not have clinical inertia. This is something that is still instilled in most of us, that we need to change the dosage as and when required, both up titration as well as down titration. So optimized titration leads to effective glycemic control. Adequate titration of insulin dose either by physicians or by patients can help in patients reach the treatment goals, including A1C of less than 7 and fasting blood glucose less than 100. So choice between algorithms may depend on the clinical circumstances and patient's willingness. This is very, very important. So medical education is paramount even when you start with a simple insulin solution of a long-acting basal insulin, vis-a-vis starting on a basal plus therapy and moving on to basal bolus therapy. So this is the algorithm that, my dear friends, that it would be ideal. You start with initial a ballpark figure of 10 units or 12 units per day, means 0.2 to 0.3 units per kilogram body weight, and change that, titrate it or up titrate or down titrate it once in 3 days. So, my dear friends, so in patients inadequately controlled with type 2, in patients with type 2 diabetes not on OADs controlled, third OAD may rarely help. So insulin should be preferred on such patients, especially when they have been diabetic for more than 5 years. So first 2 to 3 years, any drug, any kind of combination is good enough, but always go according to the pathophysiology and treat the patient according to his individual needs. So insulin resistance is something that you need to take into account before we start insulin. Basal insulin, if a patient requires insulin, I think basal insulin should be the initial insulin of choice. Patient will get the more trust because he needs to take only once a day. Probably less amount of self-monitoring of blood glucose required. Simplicity. So unless until we do things, keep it simple, patients will not adhere. So compliance is something that is worth looking into in the initial part of his treatment with insulin. So titration, easy flexibility, flexibility, either you can give in the day or at the night, lesser hypoglycemia, lesser weight gain, easy titration, very good safety profile. I think nobody in this group can ever argue that basal insulin, especially Glargine, is unsafe. Premix insulin or co-formulation insulin have disadvantages, and they have pushed them below in most of the guidelines recommendation. I'm not a person who says no for co-formulations. Co-formulations are good, but now to start with, for most of the garden variety patients of type 2 diabetes, especially for a primary care physician, I think insulin Glargine or as a basal insulin should be the first insulin to be initiated, and you can up titrate it as I have said. Thank you for your patient listening.